The conference is great, and the beginning session with AML I thought was really terrific. Andrew Way and Naval Daver are both established senior clinical investigators and have really been leading the way with many of the trials in AML, especially in elderly, otherwise non-fit patients with AML, and this is now expanding dramatically, as we see from a recent randomized Chinese study that was published in Blood recently, in the recent study presented by Amir Fati at ASH, that now this can be extended maybe into younger patients, that the use of HMA venetoclax is comparable to 7 and 3. And that really opens everything up, and that allows many more patients to get to transplant, which still remains the most curative therapy for patients with AML. Richard Dillon's talk was terrific. I thought that he also, along with just a few people in the Western world, are leaders in the field of MRD in the setting of AML tracking, and really gave a terrific, really cutting edge talk on how you should best use MRD to follow patients and to make decisions regarding additional therapies such as transplant, when to intervene with those kinds of life-threatening challenges. And it's clear that the specific tests that are being used, and more importantly, when they're being used and after which specific therapies, are now being so well defined that there's not going to be a lot of guessing anymore, which has been the case in the past. So I think that Richard Dillon's observation that when people relapse with minimal residual disease, it looks like this has to be defined in a prospective study, but it looks like they may do better with targeted therapies versus standard chemotherapy, which I wouldn't have guessed would be the case. And I think it might be due to the fact that these minimal residual disease cases are really quiescent. They're minimal, but they're also quiescent. So the role of chemotherapy in a highly quiescent disease is limited because most of the drugs are very cell cycle active and work better when the cells are dividing. And maybe when they're very limited like that, they're very quiescent, thus minimal. And so they sort of hide in the background and they're not dividing. And that may be why they're more sensitive to targeted therapies that actually target their specific mutation. So I think that made me think a lot more about how to design a lot of AML therapies in the future.